Director of the Institute for Health and Social Policy at McGill, to chair the final tweeting session.
So we are the panel standing between you and a well-deserved drink. So we're going to be doing something completely different. We've heard a lot of talks today, and we have asked a few people who we thought were particularly well situated, particulièrement bien situés, to listen and to come up here and very briefly, I've given them about 4 minutes each. Two of the people who are going to be coming up here are former ministers of health, and so I hope you'll understand if I don't enforce that 4 minutes too draconianly. I feel a little bit impressed to be up here. But the idea is to give us, I think that one of the things that we really want to take seriously, Howard, myself, and all of the members of the organizing committee, is we don't want this to be an event where we all think great thoughts, go home, and have the energy dissipated. We want these conversations to continue, and so on a demandé à 4 personnes que nous pensons.
So we asked 4 people who we thought were well positioned to listen to everything that was said today and to throw some ideas out at us that may be a starting point for future discussions. We gave each one of them about 4 minutes, and we'll also ask, as you know, following my invitation this morning, we almost broke Twitter. The tweets are going off in all directions, and we've got a student from the family medicine department who, with her superpowers, integrated, got together all of these tweets that we've created to tell us what are the main themes that came out, what are the things that you've heard as reflected through your tweets of the day. So before I ask our imminent respondents or witnesses to come, I'll ask Ayat Salman, who's a PhD student, to come tell us in 2 minutes what is happening in the Twitter sphere.
Ayat.
So, first of all, thank you, everyone. I thank you very much to everybody who communicated over social media, i.e. Twitter in this case. I'm going to talk about tweeting. In terms of the sessions and how the tweets broke down 1 to 4, we started this morning talking about Saint-Timothée, very popular on Twitter, Saint-Timothée today. Suzanne Fortier, Suzanne Portier est très populaire aussi. Il était question de la Castonguay à la méthode Barrett. And then people talked about the Dawson model, and there were tweets about, especially towards the end of the presentation of Léonard Aucoin's presentation on avenues for new solutions. And now the good question from
La question qui est très populaire aujourd'hui sur Twitter au niveau de ce symposium.
That's a question that's very popular on Twitter today. In session 2, there were a number of questions on quality of primary care. What came out frequently from
Primary care, le end-user involvement adds a lot of value. Ça a vraiment tourné autour de ces thèmes-là.
There was a lot of tweeting on that. Let me see. In session 3, the main theme was
Un peu partout avec education, educating the public. Il n'y a pas eu trop de questions aussi au niveau.
There weren't too many questions about how to do so, however. And session 4, we went back to the beginning and talking about the concentration of power at the top of the pyramid, and people talked about disciplinary institutional cooperation, pluralism, and accountability of institutions in GMF version 3. So that's a brief overview of what was going on in the Twitter sphere.
And I learned how to do it while I was actually sitting there. You actually put in the hashtag that we indicated, and there they are, all the tweets in their thousands. So you can go on and see what has been talked about. So I'd like to invite the four people that we have asked to be our grand témoin for the day to come up. And I'll introduce them. I'll introduce them all at once, perhaps, and then have them speak. The one thing I didn't mention is we will end the session with you. We thought that a lot of people have been listening for hours now, and you've all been listening to the talks for the day. So with whatever time we have left until 5, Howard has indicated to me that at 5 he would like to take an hour or an hour and a half to summarize things. But we would like to also invite you to think about if there's one or two big ideas that you got out of the day, very briefly expressed, what would they be so that we could use them to think about how to organize discussions and conversations to come around these issues. But for right now, I'd like to introduce our panel. Mark Karanofsky is the director of undergrad studies in, the light is catching this, it's printed very small on this program. Directeur du programme d'études médicales prédoctorales au département de médecine de famille. Miriam Boillat, professeur agrégé.
Miriam Boillat is a professor at McGill in family medicine, and Jean Rochon is a full professor at, I'm sorry, where is he? At health. He's a former Minister of Health and Social Services. He chaired the Rochon Commission, and Claude Castonguay, you've already heard mention of, presided the commission of the same name. So we have two of the major actors of reform in healthcare in Quebec. And his name gave rise to the expression la Castonguay. So, Mark, as you wish. Allez vous asseoir à ma place.
I wear a lot of hats. And one of them is a father, and I want to go home tonight too to have supper with my kids. Been out working for the past 2 nights. But the other 2 hats that I want to talk about today that really relate to what we've heard a lot about is one is working at Herzl Family Practice. And while family medicine celebrated its 40th anniversary in existence at McGill, Herzl was created in 1912. And we've been a clinic providing primary care for 104 years. And there's a YouTube video now that you can watch, an hour-long documentary on it, from dockside to bedside. And really, I think a lot of the themes that came up in primary care and what's been evolving has evolved with us over the last 100 years. And a lot of the lessons I've learned today from the ideas of interdisciplinarity, comprehensive health, community-based, are things that are part of the clinic that I've worked in, and I think we look forward to improving on as we go forward. And from this morning, I think I was inspired by the continuous quality improvement theme and what could we do to bring that forward. But the other hat that I've been wearing for the past few months has been as the undergrad director for the Department of Family Medicine. And I think McGill has been leading the way, maybe not on purpose, but when I look at the curriculum that has been developed over the past few years, our students now, as of the first couple of weeks of medical school, start with the foundation of family medicine. And they go into the family doctor's office, and for 16 sessions over that first year, their first real exposure to what is a physician is in a family doctor's office. So we're teaching that foundation and the continuity from the first day. And in this room are probably a lot of preceptors. And for those of you who are interested in joining our team, oh, you thought there wasn't going to be a pitch. Longitudinal.fammed@mcgill.ca. You can sign up now. We're already 60-something people already registered for next year. We need to raise 190. But that's only the first year. In the second year, we introduce our students to a second year course where actually the focus is on interdisciplinarity. We actually don't have the students with family doctors. We have them with members of the interprofessional team. And our teaching and our sessions at that point are how do we teach the members of the future to work with those professionals that are essential for providing care in the primary care structure. And so a lot of you in this room who are not physicians may be our preceptors for our students. And if anybody else wants to join for that, we're always open. But I'd like to thank the partners in our CIUSs, in the West de Lille, in the Centre-West, who have been helpful and instrumental in getting us those preceptors to allow our students to be exposed to those types of systems. And Dr. Bergman and Dr. Law provide a lecture to the students that is highly valued, going over the role of the primary care system, the GMFs, and the structure that the students are always wanting to know more about. And then in third year, our students go on their rural month. They go away, they see what life is like outside of a city, and they also get their core family medicine teaching involved with the interdisciplinarity of psychiatry. So I think as we move forward in all of these, I'm almost done. As we move forward, I think McGill has set itself up to embody a lot of these issues. But I think the challenge that I think I would learn from today is how can we involve the patient in our education? How could we, not in terms of the teaching, but in setting it up? What is the role for engaging the community in what the students should be taught in the future? And I think it's something that I will bring back to my committee as well. And how can we improve our continuous quality improvement in our clinics? So thank you very much.
Bonjour tout le monde.
Good afternoon, everyone. I'm going to share my comments in English and in French. It's easy to get discouraged. I think we've all gone through it. We experience things in the workplace that bring us down a little bit. And for those who are parents here, I don't know if you're like me, but sometimes when the kids say, oh, things are really not going well in the world, you have this reflex of, oh, no, it's not, they're not really not bad. You pick them up and you encourage them, and that's something that I would say about today. I've been very much encouraged because I feel that I'm not alone. I'm part of a community.
We're part of a community, and today I experienced this community, a community where we've articulated, I believe, a common purpose. We find a lot of common concerns and an incredible willingness to collaborate, to find solutions. And I think so many smart people in this room and so many smart ideas that it's left me with a sense of hope in moving forward. I'm going to continue on the theme of community. On a vu, je pense que le cœur.
I think we've seen that the heart of our community is the patient. And it's worth reminding ourselves of that because it's easy to forget. And I'm going to personally commit in my practice, but also in education, as Mark said, to have the patient's voice heard much more than has been the case in the past.
Community thrives, and real communities thrive when its members are kind of stubborn and perseverant and deeply committed and really believe that there will be positive outcomes and are willing to change and see things differently. So I think we can't give up. We can't become cynical. We have to have an attitude of constructive building together and move away from the us against them discourse. And I think that we need to be role models. And if I put on my teacher hat, and there are many learners in the room, I think it's an opportunity to role model how can we be resilient in the face of this difficult circumstance that we're in. La communauté, je
Community communities live thanks to their young people and express themselves through their young people. And I just wanted to comment on the presence of learners here, several of whom asked questions and made comments. I was favorably impressed by how articulate they were, how ready they were to be constructively critical, and their conviction, which was quite obvious, that they're a part of the solution to the problems we face.
bigger than ourselves. And for myself personally, as a family physician, as a teacher, I need to see something bigger than my little problems in the clinic that some of the healthcare reforms seem to be creating. And for me, Howard, this symposium is the beginning of seeing that bigger vision. And I'm confident that we will take the next steps from this symposium. Thank you very much.
Bonjour. Alors,
Good afternoon. Pleased to summarize and really summarize all of the things that have been said in the course of the day. On the basis of my experience, particularly the last couple of years, but against the background of roughly 50 years, Mr. Castonguay were reminiscing about the whole process. But there are two ideas that really I want to share with you in conclusion today. First of all, there's a situation which is not easy. There's a lot of fatigue from fighting, and there's some certain degree of discouragement. And when you look over the whole range of 50 years of history, there were lots of periods. If you look at them in isolation, you could say the health system is going through a very difficult time. But if you step back, if you zoom out, I think you can see that there has been a gradual trend in the same direction, up and down. And maybe we're in the trough right now. But generally speaking, from one period to the other, we have succeeded in saving what's essential and to build on it and to improve again. So that may mean that if we look at the situation in that light, everything is not lost, especially because, without putting on rose-colored glasses, I'm not a specialist in change management, but I have been working with people in the field for the last couple of years. But the essential thing in systemic change, if you really want to change a system, there has to be a vision that is shared by the people that make it up. And we don't have it. It has to be shared because those who carry out change are the people in the field that do it on a day-to-day basis. If they don't see the meaning, they won't move, or they won't move in the direction that was anticipated because the directions weren't properly defined. There will not be, it won't be possible to inform and to commit. Plenty have been written on the fact that for things to move, people need to be committed, including, and there have been some major experiments, including patients and community. So the winds will probably shift, but I think that we have to prepare and to start moving in preparation for the next stage. And we have everything that we need for that. The panelists have said this earlier. We don't have to ask any permission. We don't have to be combative, but you can. But it's like not boxing, but playing judo. You can play with the forces you're facing. And everything that's been done over the last 10 years, at least, there's easily 50 different experiments in Quebec that I've been involved with one way or another. Most of them have stopped, but and some partners have disappeared in reorganizations. There have been collateral losses, but there are still a lot of things that are still, and that's what we need to base ourselves on. And there's nothing that would prevent us from talking to each other. And I think the principles that were put forward in what I've experienced is that, yes, you have to have a populational responsibility vision. To properly serve, you have to be committed. You don't work only with the numerator, but also with the numerator, to take a statistician's, to use statistician's terms. You have to be able to maintain and improve the population's health by responding to people's needs that are expressed and that are and to treat people in the long term, and to work on determinants of health. Partnership, in a word. Now, in terms of how to do that, strategy-wise, we need to get away from the dynamic in which we need to think of in terms of up until now we've had a territory-based strategy, and it's everybody together in my view. It's not a particular structure or a particular geographical area. We have to think in terms of organization, coordinated activities in which partners agree, not just to get to coordinate and take into consideration what others, but to identify issues, chronic disease, people who are losing their autonomy, problems with mental health in the various populations of Quebec. You can get a pretty good degree of granularity in mapping that out. And in each area, we can come up with 5 or 6 or 7 projects, which covers most of the needs. And then we can have an approach that can work on the more acute issues and as well on health determinants. So we have to take, we need to direct the discussions today, rather than seeing oppositions and resources being taken away and granted. Now let me conclude by saying, when I said there's nothing that prevents us from doing this, there are 2 ways. Okay, to read a bill. What does it say that I have to do, and does it say that I cannot do? And if you look at it that point, there are plenty of things that you can do that are not forbidden in the bill. Thank you, and good afternoon. I think before making my remarks that we need to congratulate Howard and those who worked with him to organize the symposium today. In fact, what we did today is consistent with what people have said, that we need to act, that we must not wait, and that we have to remember that this is, we have to do what we have to do with the means that are at our disposal. So congratulations, Howard. Now, I don't want to launch off into a philosophical discourse. I want to share a couple of specific points that have been brought up in the course of the day, and that I think are worthy of our attention. But I would like to say that the Commission of Inquiry into Health that I chaired in the 60s put a lot of emphasis on primary care. And we even presented a definition of what, in our view, should be effective and efficient clinics. Clinics should have a broad view of broad conception of health, including prevention, rehabilitation, health education, hygiene, etc. And we saw them as having a certain number of doctors and nurses. We said 5 or 6 doctors would be a minimum and 9 or 10 nurses. So we already placed a lot of emphasis on the role of nurses at the time. And we talked about multidisciplinary work. And lastly, as part of their mission of the clinics, they were not only to provide health services, but also social services. Now, 50 years later, a lot of progress has been made. That's true. But there has been a constant throughout in terms of the issues that have been discussed today. These are not new ideas. These are ideas that have to continue to make their way, and at no time must be discouraged and let them drop. I haven't heard a lot of things that that agree with what is being said by the current Minister of Health, Dr. Boillat. And I'm concerned to have a government and a minister acting whereas there's practically no echo around him in terms of what is being advocated. So the question for me is, how is the Premier, who was himself Minister of Health, accept that his minister behave in the way that he's behaving? Now, on more specific points, what struck me is the importance that has to be ascribed to the primary care. People said it was the basis or the foundation of our health system, and that's true. And there was a lot of many people talked about the fact that things should not be imposed from above, that things should emerge from those who are involved in the system, from the base. Whereas at the present time, local power is practically being eliminated. The countervailing forces are almost completely being eliminated, and with the CISs and the CUSs, we're putting together institutions of a very different nature, and it's nonsensical. It's impossible for one person or one manager or a small team to manage institutions and agencies who have so completely different missions as the ones that are being put together today. Something else that struck me today is that too much power has been given to the two federations, the physicians' federations, the specialists and general practitioners, to the point where everything that involves doctors one way or another in the system has to be negotiated with the two federations. This was absolutely not contemplated by us at the time when we put forward the Health Act and the first negotiations took place. It's very clear that these two federations represent the interests of physicians in terms of their working conditions, and that's perfectly legitimate. But in doing so, they defend the interests of doctors and not of the population as a whole. The other aspect that I found very interesting, amongst many other things, is that people are asking a lot of questions. How can we continue to improve things? How can we bring about change? And perhaps the most important question that, this is perhaps the most important question that can be asked, because political power won't change overnight. It won't change as the result of a symposium, even the most interesting. So, all of those who can play a role within the system, who have the ability to think differently about things in terms of what others are trying to oppose, do so. And this is how progress will continue. And at a certain point, we've seen this in the past, there's an event, and after a period of delay, progress takes off again. We've seen some opportunities that have been missed in the past. I think the last election, during the last election, when the Premier, Dr. Couillard, became Premier and appointed 3 doctors in the government, we had an opportunity to make a major leap forward, and this was an opportunity that's been missed. The government has 2 years to make up for the lost time, and I certainly hope it does so. Finally, there is in the system, it would seem, a lot of concern throughout. People are fatigued, people are skeptical. And this message is not getting across to the population. We know that the government reacts more often to what is being said in the papers and the media than to what might be said in a venue like this. And if it's possible to get word out of all of the changes that are being imposed at a pace that is much too fast and too authoritarian, without any clear idea of where we're headed. If this message can be spread, this is something that needs to be done. So thank you very much. It was a very, very good day.
Our 4 témoins who told us what they heard in the last 8 hours. And so now the last word for about 10 or 12 minutes is, or Howard says 5, or 10, yeah, I guess everybody wants to have a drink. But if there are things that are that you've heard that you'd like to share with us, so that we can take them forward and use them to organize the discussions and the conversations to come, I think it's something that we take very seriously. Certainly was at the core of the discussions that we had at the planning meetings from the beginning, which is that this should not be the end, but a beginning. So I'm going to ask everybody who comes to the mics in the because everybody wants to go off and have a drink, to be very brief. Tweets, sort of verbal tweets. So we'll begin here. And if you could introduce yourself, that'd be great.
Je suis Marion Dove.
Marion Dove. I'm a family doctor and director for programs and family medicine at McGill. And I wanted to thank you, Mr. Castonguay, for what you've said. It really impressed me, and I think that you saw things very clearly 50 years ago. The ratio, the 5 to 6 doctors for 9-10 nurses, seems perfect for a small clinic. And I'd like to ask you if perhaps you'd like to come back in politics. Maybe in another life. All right, then second question. Would you like to come with me to meet Mr. Barrette? Before I retire, yes. I hope it was really Mr. Castonguay's birthday. Hello. Thank you very much for your words. When it comes to the whole question of how can we act now, I'm Denis Belrimont. I'm in fourth year medical school and co-founder of the Roundtable, the Quebec Students Roundtable.
So I wanted to say that I believe that the work that has to be done starts even before professionals. I think it starts when we're learners. And I would invite everybody who is a learner or who is interested in working with learners to look at our website, lefresque.com, lefresque.com. We are a group that kind of like this. We had a summit where we brought together professionals, patients, and others to look at ways to fix the healthcare system. And we're looking forward to working forward with everybody. And I want to say again, this has been a fantastic summit. Thank you so much. Merci beaucoup d'être venu.
I'm going to plug McGill Nurses for Healthy Policy. Infirmière de McGill pour une politique à santé. On est sur...
So we're on Twitter, we're on Facebook, follow us. If you're interested, follow us.
So, to close things off, I'd like to bring Howard back up.
Thank you, Daniel. Nous sommes lancés un défi, je crois.
I think we challenged ourselves today. It was a day that was full of ideas and energy, discussions, respectful discussions. The question now is, what do we do? What do we do now? How can we pursue the discussion, and what are the concrete actions that we can undertake? Danielle and myself with the committee, we've started to develop some ideas on which we will be working. But one thing is for sure.
Il y a Pierre-Luc Després en arrière qui
Pierre-Luc is in the back. He's working on that now.
detailed summary will be made public. We'll be providing a link for those who would like to listen to this whole day again. And for other people, of course. We plan to write newspaper articles and op-eds, as well as some academic papers. But more importantly, how do we continue the conversation? Sometimes I think perhaps it's time for a commission. Une commission qui génère...
A commission that would look for ideas, that would generate through discussions, that would look at the evidence and make proposals.
The changes and innovation that we've been talking about. Certain things I've heard that I think are essential: user-centered design, peer-led process, patient community engagement, diversity, one size does not fit all, innovation, entrepreneurship. Donc, merci à vous.
So thank you to all of you. I think that the discussions have made you thirsty. But I think that you stayed till the end because you are thirsty for change. So I thank you for your participation. I would like to thank the committee, Daniel Weinstock, Susan Moss, Sam Benaroya, Rita Zayed, Susan Usher. Et un grand merci à Rachel Simmons, où es-tu, qui est l'organisatrice. And I appreciate the generosity of our speakers, of our guests, our moderators, who worked very hard, who didn't just come out with a PowerPoint, but they really worked. And they contributed to the success of this day. Before we ask the Dean to have the last word, because he's always got the last word,
and leave them at the desk. And there's something I'm not sure I was told to say, but I don't understand, but the students have to sign out. I suppose you can't go home if you don't sign out. Donc, avant de...
so before going to enjoy a glass of wine together, or perhaps even more than one glass,
Dr. David Eidelman, our Dean of the Faculty of Medicine, I'd like to thank David for the support he has given to the Department of Family Medicine, to community-based care, to the development of our academic and our community mission, and I think David has really been a visionary in that sense. David?
Merci Howard, c'est un grand honneur pour moi.
Thank you, Howard. It's a great honor for me to close this symposium. I must say that I got here late because there were other events happening at the same time, parallel to this one, and I had to go give little speeches at each one of these events. And everything was said by the previous speakers, so I don't want to repeat the messages that were sent to you, except to say that I congratulate you for being here today to talk about a very important topic, the future of primary care in Quebec.
Ministers talk about what the current health minister is doing wrong. I of course have lived through all those health ministers, including the esteemed gentleman present. I would want to just end because I heard a lot of, how should I say, anger in the room. And maybe the anger is justified. But I would remind everybody that the strength of this symposium is that it's focused on the role of patients, and I heard that through a number of talks. One of the deficiencies of the Quebec healthcare system, it has many advantages, but one of the deficiencies is la définition de on n'a pas de patients.
We don't have any patients in the healthcare system in Quebec. We've got beneficiaries. That means that care is defined according to a system and not according to the person who is at the heart of our care. So my wish is that in a future reform that we will recenter ourselves so that we can be centered on the patient, on his family, and on the community.
Healthcare is about patients, their families, and the community. I know that when you're busy writing an LCATES, a law on healthcare, you have to use all kinds of technical terms, but sometimes I worry that we spend so much time worrying about the system that we don't worry enough about patients. And so what I think is a great strength of this conference, at least the part I was able to attend, is that the focus was really on how, as clinicians, how as interprofessional health workers, we can make a difference for our patients, for their families, and their community, and that's a great success. Alors, bravo. Pour terminer.
In closing, and to allow you to go have a cocktail, it is my duty to congratulate all the participants, to thank the speakers, and especially to thank all the people who worked on this symposium.
Sincere congratulations to the Department of Family Medicine on their 40th anniversary. I did notice Dr. Karanofsky did point out that Herzl is older, but the Department of Family Medicine is 40 years old. And I also wanted to say, you know, one of the problems about being a dean is you get these young people who come in your office and they just push you hard. They just insist that you do things for them. And sometimes they're department heads. So Howard Bergman comes into my office on a regular basis and he pushes. And you know, with these young people who push so hard, you have no choice but to listen. And so it's been a great pleasure to work with Howard, and I want to just join you in congratulating him and his team on a fantastic symposium. Have a nice drink.